Hi everyone, and welcome back to the conclusion of the androgen overexpression series. This is essentially the culmination of several efforts, taking data from over 20 attempts over 10 plus months by now. It's meant to be a cover all your bases approach, meaning it exhausts the path of hormone treatment as a curative method. What I mean by this is if you follow the steps that will be outlined in this video, you should be able to rule out a hormonal intervention as a way to improve or recover from your syndrome. I've done my best to make this the most responsible way to go about a hormonal intervention, meaning nothing that I will suggest in here is potently toxic or dangerous for anyone, so long as they're in good health to begin with. Now, there hasn't been enough data for women, unfortunately. All of the trials have been men. And so, as a result, what follows refers to men only. It's going to be impossible to fully explain everything and all the concepts in this video and remain concise. So, you will need to have some basic knowledge of what we're talking about here beforehand in order to understand what I'm going to say in this video. Okay, so moving on to the prerequisites. First of all, please make sure you have visited your medical professionals. You absolutely must rule out other causes and also ensure you have no underlying health concerns that would make such an intervention dangerous for you. The first part, ruling out other causes, is also a very important part of fitting the diagnostic criteria, which we'll talk about soon. Second, understand that this is not medical advice. I'm not a licensed medical professional. You assume full responsibility for your own health. Third, make sure you can afford frequent blood tests and hopefully the supervision of a medical professional. If you can have a doctor watching over you and greenlighting the whole process and telling you you're okay and healthy and safe to carry on forward, all the better. Understand there are no guarantees. I'm fairly confident that the majority of people that follow this closely and fit the criteria well will see some degree of improvement or will be pointed towards a trajectory which they can then follow and improve further. However, there's absolutely no guarantee that's going to happen for everyone. So keep that in mind. And number 5, you absolutely must fit the diagnostic criteria as outlined by Dr. Healy and his research partners in the link in the video. Which brings me to the next point of the video, fitting the diagnostic criteria. The diagnostic criteria represent the most substantial body of research and data that currently exists on the conditions. In a situation like this, where there is very limited actual evidence to follow, we cannot afford to be dismissive of what actually exists. Now, fitting the diagnostic criteria is absolutely crucial in order for this to work. The suggestions outlined and the information it's based on have been tailored around and gathered from people with PSSD and PFS. It is not meant for irrelevant conditions and will absolutely not work for them. One example is CFS, another is withdrawal from opioids or antipsychotics, and the list goes on. It would be entirely irresponsible and downright stupid to undergo expensive hormonal interventions on the internet for a condition you essentially do not even have. Now, 2 common examples that do not fit the criteria. Having taken a medication that is not listed in the criteria, antipsychotics, opioids, obscure supplements, lion's mane mushroom, licorice, shampoos, ashwagandha, and others do not constitute suspect medications for PSSD or PFS and do disqualify you from the condition. Now, I do not care to deny that anybody may get a similar condition from one of the above substances. However, currently, strict adherence to the available evidence does not allow for the above assumptions. To say that any of the above medications gave you PFS or PSSD is simply groundless speculation. Unfortunately, this happens all too often in the PSSD and PFS communities. People show up who have taken entirely irrelevant or obscure supplements or medications that are not only irrelevant, but at the same time, there's simply no proof that they even have similar properties to SSRIs or 5-alpha reductase inhibitors in the first place. Major example of this is what happens with lion's mane mushrooms. For some reason, it's considered a given that lion's mane mushrooms can give you PFS. However, when you actually try and look up lion's mane mushrooms, you will find there is not a single study that has found any sort of 5-alpha reductase inhibition from lion's mane. So there's not even a single shred of proof that lion's mane mushrooms are 5 ARIs, much less that they can cause PFS. So although I'm not denying anybody's experience with these supplements, that does not mean you have PFS or PSSD as they are currently defined. Moving on, a few more examples. It's been made clear, both in the Diagnostic Criteria and by Dr. Mulkanji more recently, that dysfunction while on the medication is not the same as dysfunction after the medications have been stopped. The first is caused by the medications directly and can be easily explained. The second is not as easily explained, as it remains long after the medications have been discontinued and are no longer acting, not having allowed enough time after discontinuing the medications. So symptoms must persist for a minimum of 6 months after discontinuation. That's for a lot of reasons, one of them being that med withdrawal is an important consideration and not the equivalent of the syndromes. So a lot of people do not understand that, for example, after you're done taking an SSRI, you're not supposed to be golden on day one. Not only does it take a good while for the medication to clear your system, but it takes a lot longer for the withdrawal syndrome to wear off. And it's likely that it takes even a bit longer than that for the changes that have taken place in your body to return to how they were before you took the medication. And the same thing happens with finasteride or dutasteride for that matter. Third, currently taking other psychotropic drugs, sex hormones, or having other conditions that relate to sexual dysfunction. This includes undergoing transgender HRT. If you're currently taking antipsychotics, opioids, any other medications that affect you mentally, or you suffer from other conditions that may relate to sexual dysfunction, you cannot be diagnosed as having PSSD or PFS. Some examples: chronic pelvic pain syndrome, other hormonal disturbances like thyroid issues and whatnot. So anything else that can explain symptoms automatically disqualifies you from being able to be diagnosed with PSSD or PFS. The simple matter of the fact is you need to absolutely fully rule out any other issues you may have that may explain your symptoms. And you need to be fully off any other medications that may do so as well. Now, the transgender HRT part, having entirely changed the hormonal environment of your body, does also disqualify you from being diagnosed as PSSD or PFS, as it can on its own explain the entirety of your symptoms. Now, some people can get away with it for various reasons. Maybe they're not influenced as much, or maybe they eventually get used to it, and that's all great. However, you simply cannot expect this to go perfectly well for everyone, and it is a widely and all too often discussed issue. So I'm not saying that it's impossible to be trans and have PFS or PSSD. It's not impossible at all. You simply cannot be sure it is the case until you have restored your normal hormonal environment. And quite some time has elapsed as well. Essentially, the point of all this is anything that may be causing or adding to your symptoms automatically disqualifies you from the syndromes as stated in the diagnostic criteria. Finally, if you are excluded from the above criteria for any reason, I would say that's actually a good thing. It's much preferable to be able to attribute your issues to anything other than PSSD or PFS, both very obscure and difficult to treat syndromes compared to essentially anything else. If there is any other probable etiology, you should and must focus on ruling that out fully first. So yeah, I see a lot of people feeling sort of disappointed, or sometimes they even get defensive if you tell them that for whatever reason they do not fit the diagnostic criteria. I just don't understand that sort of behavior. It's simply much better to not be able to be diagnosed with PFS or PSSD, because that means there's a much more likely cause for your issues, and that cause is most certainly easier to treat than PFS or PSSD. Okay, so moving forward, first of all, a quick overview of what is about to follow. So the plan, as I'm going to show it to you here, is based on the original theory that I published a year ago and has been adjusted according to how all the trials went. It prioritizes and maximizes safety and stability in order to minimize side effects and adverse responses at the cost of speed. So if you want to do something right and safely, you have to do it slow and take your time, and it's a much better way of knowing where you're at any time. As soon as you start trying to go quickly about things, that's when you end up not knowing what's affecting you in what way. So how long this will take is not a given, especially in case of a positive response. Some people may need more time, others will need less time, so there is no set length. However, in case of no positive response, by the end of month 3, you will have tried everything this plan has to offer. There are a couple alternative approaches after that you could try if you want to, but we'll talk about those later. And quickly, how it's going to look is you get your testosterone and HCG base in, and you move on to a quick androgen trial, then you move on to hops, and then finally estrogen. There's a lot of reasons for the androgen trial. I'm not going to get into the specifics of it. It will just add unnecessary time to the video, but what I'm quickly going to say is men getting better from using androgens is nothing new, and it's certainly much less unexpected than men getting better from using vast amounts of estrogen. So for that reason, and for a few others, everybody should run a quick androgen trial before they move on to trialing estrogen. As I already mentioned, the core of the plan is a TRT dose of testosterone and HCG. This is necessary to maintain overall health, function, and fertility, and has a well-established safety profile. Overall, nothing that will be used throughout the plan is toxic or potently dangerous. However, all medications carry certain risk profiles. Educate yourselves on the issue if you have concerns. About estrogen or estradiol, the only data we have comes from transgender HRT and androgen deprivation therapy in men. In both cases, we're seeing that it's well tolerated and not dangerous. The duration of the treatment is not long enough or in high enough doses for serious concern. Now, with the use of androgens, especially in high doses and for prolonged periods of time, there are certain risks that come into play, such as your lipid profile getting worse or hematocrit rising. However, the way we're going to use them in this plan will not allow for these risks to be serious concerns unless you have pre-existing issues to begin with, which is why I said at the beginning of the video, everybody must confirm with their doctor they're okay to run a short-term hormonal intervention. But what I'm saying here is nobody will be running anabolic doses of steroids here or liver toxic drugs. No such thing will be taking place. As far as the trials are concerned, no serious adverse events or negative changes in blood markers showed up during any proper trial. Things to watch out for. First of all, monitor your blood pressure often. I suggest everybody gets a home blood pressure monitor and you get readings at least 3 times a week. Blood pressure readings should be taken either in the morning, slightly after waking up, or at night before you go to sleep. Second, the more often you get blood tests, the better, and samples for blood tests should always be taken on the morning of an injection day before injecting anything. You will find a collection of blood markers that you should be on the lookout for in the description of the video. Just a quick note, you should keep an eye out for your hematocrit. Some people may see it going higher than the acceptable range on TRT because of the stimulation of erythropoiesis. However, it's very unlikely that you'll get this issue. And there are also other ways to deal with high hematocrit without stopping TRT. Number 3, exercise as much as you can. Obviously, exercise is great for anyone, whether you have PSSD or not, and whether you're undergoing any sort of treatment or not. Exercise just does an awful lot of good to you. If you can get some weight training and a bit of walking in or some light cardio, that's great. Placebo and stress are both a big issue, and they are sort of interconnected as well. I'm not going to go into detail about the importance of placebo, but I will link to an Instagram post that I find adequately demonstrates how strong the placebo effect can be and how everybody is affected by it. And if you know how placebo works, you definitely want to have placebo on your side, and you don't want to stress yourself unnecessarily by either catastrophizing or constantly making negative thoughts about your situation and your outlook, or thinking that you're doomed for life or anything of the sort. It can have a profound effect on your recovery. Now, for this reason, one thing I absolutely recommend to everybody who wants to get better from PSSD or PFS, regardless if they're going to follow what is outlined in this video or not, is stay away from communities that are overtly toxic, depressive, and anxiety causing. Now, if you've been in the server, you know full well I don't exactly get along with the PSSD subreddit, so it may come as no surprise to hear me say something like this, but honestly, and personal quarrels aside, the PSSD subreddit is possibly the best example of an overtly toxic and depressive community. And I really suggest, if you want to get better, that you stay as far away from it as you can. Number 5, gyno is also a very large issue and a detailed one, so I couldn't go through all the details of it without adding minutes to this video. So I'll just quickly sum up what the expectations are during this trial. So it's not likely, but it's always a possibility when using estrogen. As estrogen is one of the hormones promoting breast growth, the other two being progesterone and prolactin, you cannot rule out the possibility of getting a degree of gyno when you're using estrogen. However, so long as androgen presence is strong in breast tissue, gyno will be kept at bay. And at no part during this trial will you be inhibiting your androgenic activity in the breast tissue. Now, temporary puffiness, water retention beneath the area is much more probable, and you may even see some temporary softness or enlargement of the nipple area, but that isn't gyno. It may appear alongside pruritus or discomfort, and it quickly goes away as soon as you're done using E2, or even if you're still using E2, raising your androgens will also take care of it. Hair loss can be an issue for some people who are especially sensitive to it or genetically predisposed to having hair loss. For those people, even the standard TRT dose of androgens, so just testosterone and HCG, may cause them to have hair loss. The way we're injecting testosterone here, meaning the frequent injections, helps temper that a little bit. However, if you're genetically predisposed to it, you may get it regardless. If you're not genetically predisposed to hair loss, you most likely won't experience any of it. Number 7, if at any part you feel that your health is negatively affected or you feel extremely unwell, just discontinue treatment, cease all medications, be responsible about it. Now, the only medications that I don't recommend you stop immediately if this happens is testosterone and HCG, and instead, for those two, you should follow the instructions about getting off of hormones entirely, which you will see in a later part of the video. Moving on to the main stack. First of all, testosterone cypionate. That's your testosterone base. HCG, that's to maintain fertility and testicular function, as well as for a few other good reasons. Number 3 is estradiol benzoate, and that's an injectable form, and estradiol cream, which may not be 100% necessary for everybody. However, those who suffer from genital numbness as one of the strongest symptoms may disproportionately benefit from estradiol cream. Proviron, otherwise known as mesterolone, preferably in injectable form if you cannot find that, because I know it's quite hard to find it injectable actually. Oral will do as well. Mifepristone, that's progesterone antagonist. You'll need about 5 grams of mifepristone. And finally, tadalafil at 5 milligrams. This will help with increased blood flow, which is an important factor in recovery, in my opinion, while also having some beneficial effects for your cardiovascular health. So tadalafil, 5 milligrams taken daily. As far as supplements are concerned, you're going to need hops and iron bisglycinate. The reason why everybody should get iron is to prevent iron depletion from erythropoiesis. So all androgens stimulate the creation of red blood cells. In order for that to happen, your body taps into your iron stores. Iron is essential for the creation of new red blood cells. That oftentimes causes the depletion of iron levels, and that can lead to iron deficiency syndrome or iron deficiency anemia. Iron deficiency anemia means you are not creating enough red blood cells anymore because you're depleted from iron. Iron deficiency syndrome arises directly from the insufficiency of iron in the body. If you have an anemic trait like thalassemia minor, like I do, or if you are chronically iron deficient and you suffer from iron deficiency anemia, or you just have low iron for whatever reason at all, using iron bisglycinate is an absolute must during this whole process. Otherwise, you will feel like crap. And that's a given. Even if you've not ever suffered from low iron and do not have any of the anemic traits, I still suggest you get iron bisglycinate and just supplement with it once in a while, just to make sure your iron stores remain sufficiently full. Now, obviously, you will be monitoring your iron through your blood work as well. So if you see that your iron is high enough and has no problems whatsoever, then you don't really have to supplement. But I suggest everybody supplements with iron depending on their own individual needs and conditions. Everything below these two is optional and aimed at overall health improvement and maintenance, covering our bases, as well as risk minimization, so minimizing health stress induced by the hormonal meds. And that's fish oil, taurine, and vitamin B12. Vitamin B12 also plays a part in the creation of red blood cells, and a lot of people seem to be deficient in vitamin B12 to begin with, so it's always good to cover your bases with some vitamin B12. Fish oil and taurine are both just supplements that seem to provide adequate health effects to be considered in a general supplement stack. That's all. There's no other importance to them. They're just good for cardiovascular health and health in general. However, if you really don't want to take them, don't want to spend money on them or anything, feel free to do so. So finally, getting to the plan itself. Step 1 is establishing your testosterone base. That will be 140 milligrams of testosterone cypionate per week. This dose is the TRT standard and a good middle ground that seems to land most people at the high end of the natural range, which is where we want our levels to be. You can adjust to as low as 110 milligrams or as high as 170 milligrams, only if you're absolutely certain you feel better that way or your blood test showed lower or higher than ideal levels. In reality, most people will only have to adjust downwards, and it's likely that a large portion of the people who try this would be better off at 120 milligrams, but that depends on the individual. So a few people tend to show higher than physiological range T levels, even with lower than 100 milligrams doses. Despite that, I would keep the dose to 110 milligrams as a minimum. If you had to choose between lower than optimal or slightly higher than optimal, then I'd go with slightly higher than optimal in this case. 4 weeks before step 2. Make a note of your baseline after 4 weeks of testosterone in order to know how the future steps affect you or whether you need to adjust your T dose. So at 4 weeks in, you're going to know if you should be on lower levels of T. Normally, it takes more than 4 weeks for your levels to stabilize, but with daily injection frequency, as I'm just going to suggest, 4 weeks will be adequate time for you to know if you're on too high levels or not. So ideally, you want to split your injections into 7 daily injections down to a minimum of 3 injections per week. So if you absolutely hate injecting or your schedule cannot allow you to inject daily, then you can go down to as low as 3 injections per week, but I highly suggest you stick with 7 injections unless you have really good reason. Higher injection frequency stabilizes your levels quicker and maintains a more stable hormonal environment with essentially no big ups and downs and an optimal ratio of aromatization and 5-alpha reduction, minimizing side effects. It's best to inject in the morning. So again, this way mimics your natural function and natural testosterone production most faithfully. You can inject subcutaneously or intramuscularly. Ideally, just pick one and remain faithful to it. It doesn't make too much of a difference. It's fine with me, whichever way you choose to go. Moving on to step 2, we will be introducing HCG. You start at 1000 IU per week. Ideally, again, daily injections down to a minimum of 3 per week. And 1000 IU is enough to maintain testicular size and function for most everyone, with minor exceptions. Minimum of 3 times per week keeps HCG working throughout the week with no interruption, subcutaneously or intramuscularly, depending on preference. Again, I don't really mind. Minimum dose of 700 to 500 IU per week if you're not tolerating it, and 2 weeks on T plus HCG before step 3. So you allow 4 weeks on testosterone before introducing HCG, and after you introduce it, you allow 2 weeks on T plus HCG before moving on. If, for whatever reason, you see that you're unable to tolerate 1000 IU of HCG, then you can go lower down to a minimum of 500 IU. And this brings me to my next point, knowing how to adjust testosterone or HCG if necessary. First of all, not much is expected to have changed at this point. T plus HCG is your base. It should remain steady and injections carry on until you're ready to entirely come off of hormones and for no other reason. So even if you're under the weather, you got the flu, you got COVID, if you want to, you can absolutely pause any other step, but your testosterone and HCG base remains steady until it's time to fully come off. Occasionally missing an injection is not a big deal, but do not do so unnecessarily. Make sure your baseline is relatively comfortable on T plus HCG. No uncomfortable side effects should be present. Adjust downwards if those present. Adjusting upwards is unlikely, as I said before, to be necessary. This is where I want to add a small note. Before adjusting HCG for whatever reason, I suggest you first lower your T dose to 120 milligrams and give it a bit of time there and see if that improves the majority of the side effects that were brought on by the initiation of HCG. If that does not happen, then you go and lower HCG down to 700 IU per week. Now, 500 IU may be slightly inoptimal in terms of maintaining testicular size and function fully. The majority of people out there won't find 500 IU to be enough to fully maintain testicular size. So only go that low if you're absolutely certain that HCG is causing you trouble. Finally, 6 weeks in is a good time to get blood tests and confirm all is well, including your T levels not being too high or too low. If you're wondering if your T levels are too high, this is what you look for. If you're feeling overstimulated, slightly on edge all day, slightly irritable and anxious, sort of like you've had a bit too much coffee all the time, that's when you know you should be lowering your T levels. Being too high on testosterone or too low on testosterone can present in various ways across individuals individuals, but to the best of my knowledge and experience, the most reliable way to tell your T is too high is what I just described. Some people here may say, oh, it's your estrogen, or it's just HCG doing this and whatnot. I'm not going to get into this conversation right now for the sake of keeping the video short. My advice is, if you're feeling as I described before, simply lower your T dose to 120 or 110 milligrams per week. Moving on, step 3 is androgens. Weeks 6 to 8 will be 2 weeks of misterolone at 75 to 125 milligrams per day. You start with 50 milligrams for day 1, up to 75 milligrams on day 2, assuming all is well, and you remain on 75 milligrams for the 2 weeks unless there is no response 2 days in. If so, go up to 125 milligrams, always in increments. Misterolone has a 12-hour half-life, so split doses into morning and evening. You can take the largest part of it in the morning if the evening ingestion causes you sleep troubles. For example, you can take 50 milligrams in the morning and 25 milligrams in the evening if you're taking 75 milligrams, or even if you're taking 100 milligrams, you can still take 75 in the morning and 25 in the evening. Misterolone is a steroid with low anabolic activity and high androgenic activity. The purpose of using it for 2 weeks is to cross out low androgens as a root cause and also to gauge response. Be attentive to how you're feeling and responding to the medication, including mental and physical effects. If your overall response is negative, move on to step 4. If your overall response is positive throughout the 2 weeks, you should switch your attention to focusing on androgens and lack thereof as a root cause of your issues instead of proceeding to E2. This seems to be the case with a small amount of people. If you happen to be one of them, then you do not move on to estrogen and you pursue using androgens. Now, how you're going to do that is outside the scope of this video. Point here is, I expect most people with PSSD and PFS to have a negative response to using misterolone, as is predicted by the theory and what we talked about in the previous parts of the series. Of course, it goes without saying that if you feel misterolone is making you worse, and by day 5, let's say you're absolutely certain, then you can stop it early. You don't have to go through the whole 2 weeks of it. I should also add here that 1 day of misterolone is not enough, so give it at least a few days. Step 4 is hops. 4 grams per day for 2 weeks, split equally throughout the day. And regardless of how you respond, you proceed to step 5 after 2 weeks. If you can tell early on you can't tolerate hops, you can stop it at week 1 and move on. Responding positively to hops is not an absolutely necessary thing, but it's a good thing when it happens. And for some people, these 2 weeks may be crucial in setting up the use of estrogen. Week 10, if you have managed to procure mifepristone, use 600 milligrams per day for 1 week. Should be well tolerated with no side effect. If you do not have mifepristone, proceed with E2 as stated below regardless. Week 11, start with 1 milligram of E2 benzoate. If well tolerated, go up to 3 milligrams every other day for 2 weeks. You can adjust down to 1 milligram or up to 5 milligrams depending on the effects you're experiencing. There will be some buildup of E2 despite the short ester, so do not overextend carelessly. Along the way, watch out for improvements, initially in the mental department, for example, the return of feelings, lessening of depression symptoms, improvement of brain fog, anhedonia, romance and libido, and later on in the physical department, genital numbness, ED, dry skin, energy and strength, cardio performance during exercise. If you were dealing with a full brunt of PSSD and struggling with severe inability to experience pleasure or reward, apathy and lack of emotion and despair, E2 should not have any negative mental effects on you and should help with all of the above. However, if your issues are mostly in the sexual department and the negative psychological effects you experience stem from those dysfunctions, for example, catastrophizing and depressive thoughts, E2 may cause anxiety and further vulnerability to negative emotion. In this case, use the lowest dose you can tolerate for 2 weeks to see if your sexual functions improve. Also in this case, you can try supplementing with 25 milligrams of Proviron twice per day, which may alleviate some of the negative psychological effects. And in this case as well, you can focus on using solely estrogen cream, which is bound to have a more localized effect than the estrogen injections. Next up, just a few notes on the estrogen cream and how to use it. You can go through these for a few tips. Make sure you pay attention in the last part. Don't rush to skipping E2 injections in order to use cream. It's not going to have exactly the same effect profile. So by now, we're at the end of week 13. If you've experienced any degree of improvement, follow these steps as outlined in this slide. I'm not going to read all of them again. I've tried to make them as elaborate as possible and have most of the information written down on the slide so you can always backtrack to it and refresh your memory. Not much else to add here. In case you did not experience any degree of improvement by end of week 13, I suggest you move on from a hormonal approach. Otherwise, you can try one of the alternative approaches as I'm about to explain next. Before I do that, I just want to quickly explain how you stop testosterone and HCG smoothly. First of all, you stop injecting testosterone. Then you increase your HCG dose to 2000 IU per week. Remain on that dose for 5 to 6 weeks until the testosterone is entirely out of your body. 5 to 6 weeks is how long it's going to take until the vast majority of it is eliminated. If this still results in too heavy a decline of T levels and you start experiencing side effects, you can use either a higher HCG dose or do another 8 milligram shot of testosterone, but be aware the second option will extend the amount of time you need to remain on HCG by 4 or so weeks. Obviously, these doses are just examples, and so you may need a slightly higher HCG dose, or you may not need as much. You can always adjust based on the way you're feeling. It's impossible to specify the dose that will work for everyone in a single video. Step 4, you start gradually reducing your HCG dose by 500 IU per week. If this still feels too quick and is causing you withdrawal, you can extend the time between reductions as needed or introduce further steps by reducing the decrements. If you're especially worried about getting off of testosterone and HCG, you can use something like clomiphene or even something like Clomid. I personally don't suggest anybody uses Clomid. I fully believe you can very smoothly come off of TRT by just using HCG and tapering down slowly. I want to explain a couple of alternative approaches for those that didn't get result with the protocol outlined thus far. In PSSD cases, if response to anything in the plan was minimal to non-existent, you could reinstate an SSRI at the lowest dose while on TRT. When you're mentally better, you can very slowly go off the SSRI by reducing frequency of ingestion. Ideally, I would pick one of the SSRIs least known to interfere sexually. Obviously, escitalopram is the worst SSRI you can pick for this, as it is the one most heavily associated with sexual dysfunction. Now, that is certainly going to be affected by the SSRI while you're on it, and that's just an effect the SSRIs have. However, coming off of it should be a lot easier and may restore normal function both mentally and physically. Now, in PSSD cases that responded positively but insufficiently to HOPS and E2, and in PFS cases, you can try using dutasteride at 0.5 milligrams twice per week for 2 weeks while on TRT and HCG. Now, dutasteride is potent enough that you're not going to need more than that. After taking dutasteride, try using E2 again as before. Do not go higher than 2 milligrams with each dose this time, as E2 effects will be much stronger with the absence of DHT. Two things you need to be aware of if you attempt this route. Dutasteride has a 5-week half-life. This means your 5-alpha reductase activity will be back to normal around 6 months, approximately 5 half-lives after your final dose. Full restoration of DHT effects will take 2 to 3 months longer than that. So you will be committed to this, but the DHT restoration process can always be fairly well sped up and held along by supplementing with misterolone and Dractim, which is DHT cream, or drostanolone. Furthermore, by using dutasteride, the possibility for gyno becomes very real, as DHT is essentially what prevents the growth of breast tissue in males, and you will be inhibiting that with dutasteride. But should most definitely go away when your DHT production is restored, and that can be further aided with misterolone again, drostanolone, or Dractin, so DHT cream locally applied. Now, I'm not personally worried about PFS when you're taking dutasteride. I've taken dutasteride multiple times myself. I think when you're in an optimal androgen range, so when you're using TRT and HCG, then you can maintain optimal levels of testosterone. You're much less likely to get any PFS level of adverse effects, especially if you can always supplement with a bit of DHT if necessary. But due to the lack of complete understanding of how these syndromes work, the risk cannot be ruled out entirely. So that is essentially the entirety of the protocol. Just a couple of things I want to say before we close. First of all, the effects of hormones take time. Unlike many other medications, hormones have delayed effects, so don't be disappointed if you don't see instantaneous results. Give it a bit of time and patience. Second, the natural hormonal environment for a male is not one where E2 is constantly spiked or at very high levels. This is only meant to be a temporary intervention until it's no longer necessary. And what you want to be seeing is small improvements along the way. Third, obviously this is just my opinion based on my experience and knowledge on the subject and what I've seen so far. However, it is apparent to me that there is no long-standing physical damage to anyone with these syndromes. Essentially, what I'm trying to say is your body is healthy and your brain is, for lack of better words, stuck in a bad loop. Both are capable of recovering just fine. You're not permanently ruined, so keep a positive attitude. And I'm truly confident that if you allow yourself to understand this first and foremost, you will one way or another end up recovering, whether it's this treatment that does it for you or anything else. And finally, if this video or this approach helped you, or you want to support me and see more of this content, there are a few Amazon links in the description of the video which you can use to buy the suggested supplements. You can also tip me on PayPal following the link you'll see on the screen. And finally, for consultations, or if you want me to follow you along the protocol, shoot me an email at this email address and I'll get back to you as soon as I can. Thanks for watching, and I hope this ends up helping you out.